Welcome everybody for being around. It's a pleasure to introduce Dr. Kalkanis. Dr. Kalkanis is a native of Michigan, and he's what you call Triple H. There's very few people in neurosurgery that are Triple H. So he went to Harvard undergrad, he went to Harvard Medical School, he went to Harvard Neurosurgery. He's been on top of his class for everything. I was teasing him. He went for a little stint to Oxford for a summer program. Even there he was #1 in the class. So he's really had a brilliant sort of academic career. He then went to Henry Ford Hospital where he rose up the ranks. And he was recently appointed as chairman of the Department of Neurosurgery there, which is affiliated with Maine State. He's really made seminal contributions. His guidelines for brain tumors is really one of the seminal things that was published in Journal of Neuro-Oncology. He has over 100 publications and book chapters. He's really recognized as one of the leading tumor surgeons in the world. He has a really excellent clinical trials that are done in Michigan. But he also gives a lot of time to organize neurosurgery. I know I was involved in Congress, and he spent a lot of time working in the Congress with guidelines, and he's the scientific program chair for the meeting in New Orleans, and was recently appointed treasurer and secretary for the CNS. So he's been really a great sort of a working beat for neurosurgery. You know, people sometimes think, oh my God, these meetings are great. There's a lot of work that goes behind it. Steve has been very active, not only in academic neurosurgery, but in organized neurosurgery. He's really the quintessential triple threat. He's an academician, researcher, educator, and a great surgeon. So without much further ado, Dr. Steve Kalkanis.
Thank you very much for that very kind introduction, Anil. It's a great pleasure for me to be here. I've actually been looking forward to this trip for a long time. Have heard many wonderful things about this program, and it really just shows that leadership matters, and what Dr. Nanda and all of you have been able to build over so many years is legendary. And I'm particularly proud to have met many of you. Hope to meet the rest of you at dinner tonight. You know, Anil, and I can say this truly from the bottom of my heart, he is, I think, the most erudite and captivating speaker that I've ever met in neurosurgery, and so it's a little intimidating to be here in front of you. And I was talking to Dr. Misios last night. It's also particularly auspicious that with all of your knowledge of world history and international cultures today happens to be Greek Independence Day. So you have at least 2 Greeks in the room who, so many great reasons to be here, not the least of which is that it's 30 degrees in Michigan today, so it's an early spring today. And I know we're going to talk about the book later on at dinner, but what an innovative thing for a journal club. I'd never heard of that before, and I thought, gosh, you know, I can't remember the last time I sat down to read a book like this for pleasure, which is terrible. We should all do it more often. But I was equally captivated and reminded by the story of how important it is in medicine to never lose sight of the perspective of our patients, and also to realize, and I think this ties into the theme of innovation and some of the things I'm going to talk about today, that no matter what stage of training you are in your career, whether or not you're a medical student or a resident or an attending, every day is a new opportunity to make a difference and a discovery and to ask questions and to continually push that envelope, because there's so many things, especially in neurosurgery, for what we do, that is a lot of it's still a black box, and there's so much room for discovery that I think that it has important lessons for all of us. So I'm going to talk a little bit today about what I spend a lot of my time doing clinically, and that is how to treat malignant gliomas, and what is the best way we know in 2015 to try and really attack this dreaded disease. And one of the ways, obviously, as surgeons, is that we're constantly asking about, you know, does surgery matter? And how far can you push the envelope to chase these cells, and can you make a difference for our patients? And when you think about constantly trying to improve, it's astounding to me how many examples there are, even in our own field, and I'll share with you a couple of those that we're involved with at Henry Ford, of continually trying to push the frontiers forward. We all think of Steve Jobs and Apple, for instance, with innovating a relatively commonplace object like a phone and changing it completely And I think that the same requirement, if you will, needs to happen in brain tumors to really make a difference for our patients. And when we talk about the beginnings of our own field, you know, I think of Harvey Cushing, who was truly one of the first innovators. And it's interesting that not only that he was a quintessential physician scientist, but he really had a major influence on society. There's little known stories of the irony, actually, of his friendship with Franklin Roosevelt. And in fact, one of the first ways at the time before the imaging era that people knew that Franklin Roosevelt had actually suffered a massive intracranial hemorrhage is that he actually presented with the response that Cushing first described, with elevated intracranial pressure. And so when you stop and think about how far we've come, 65% of all patients who entered a neurosurgical operating room in his era died. I mean, just think about that for a second. And so there's obviously a lot more room for improvement, but that's something that I think is very humbling, that over the last century we've really made great strides, but certainly there's a lot more to go. So when we talk about tumors, interestingly, the vast majority of intracranial tumors are metastases, 500,000 or more, depending on the case series that you look at a year. But the most challenging, the ones that really sort of perplex researchers around the country are GBMs and the malignant gliomas, because they pose a range of challenges. And getting back to those initial pictures I saw, what is the best way to treat a patient like this? How do you actually offer hope in the face of all odds? And we talked about in Cushing's time 65% mortality, but until lately, our track record of survival in GBMs was abysmal. When you think of all the other advancements in medicine over the last half century, and you look at survival for glioblastoma, you know, there are a few inflection points. The first one beginning with intraoperative navigation and doing safer surgery. That gave us a little bump in survival, maybe a few weeks to months. Gliadel, impregnated BCNU wafers, is actually the only approved, from an FDA standpoint, treatment intracranially in terms of chemotherapy for GBM, and in fact that gave an additional 13.6 weeks, clearly not a home run. The Stupp protocol in the temozolomide era, which we'll talk about, was sort of the next big inflection point, and over the last 5 to 10 years, the rise of Avastin and what that may or may not mean, certainly it improves the imaging picture, and there's some anecdotal evidence to suggest that life expectancy is preserved, but we have a long way to go. And I think that the current statistics suggest that if you are diagnosed with a GBM and you're sent to a major center like this one and have state-of-the-art brain tumor surgery and radiation and chemotherapy, maybe a clinical trial. You know, 10 years ago, your life expectancy was about 11 or 12 months. Today, it might be on the order of 18 months. But we're constantly looking at that outlier, that edge of the curve that I'll show in a few minutes, where we have a growing proportion of people who are, in fact, quote-unquote, long-term survivors, meaning they're living more than 4 or 5 years. And now, more than ever before, it's particularly exciting because we have tools that we didn't even know we needed or that even could exist a few years ago in terms of the molecular genetics and the molecular pathways to explain some of these variations between short and long-term survivors. So I'm a big proponent of the tumor board process for sort of bringing everybody together, and I know that Dr. Misios and all of your colleagues here have recently started a weekly conference. We do ours weekly, and I think it's important to offer in real time solutions for actual patients that are presented. At Henry Ford, this is really the mainstay of what we do. We see about 700 new brain tumor patients a year, 7,000 patient visits. We see about 50 patients on average every week in our tumor board process, roughly about 2,000 evaluations per year. And we have now, this number's over the last month or so gone up to about 4,000. It's one of the largest in the country in terms of our tumor bank, and we're proud of that because I think that that has allowed us to participate in clinical trials and in tissue-based analyses where now we're moving toward the concept not just of a tumor board, but of a molecular tumor board, so that we soon hope to have the ability for every patient who comes through to talk about the relevant molecular markers and the treatments that may make them amenable to certain phase 1 clinical trials. So we participate along with MD Anderson in the Cancer Genome Atlas, and that has yielded significant results. And in terms of generating these clinical trials, some of which I'll mention in a minute, one of the things that we looked at early on is to figure out what truly is the difference between short-term survivors and long-term survivors. And over time, I mentioned earlier that we had about 11.8 months survival in the 1990s compared to about 16 months in the mid-early 2000s. But we had a tripling at the same time, interestingly, a tripling in the number of long-term survivors. We attribute that to better targeting and precision and personalized medicine, and we discovered about 18 cancer-related genes that turned out to be significantly and only upregulated in short-term survivors, including RAF1 and several others, but 5 corresponding genes were downregulated in the short-term survivors, including IL-2 and some TGF-beta family members. And so putting this all together, we're able to develop sort of scatter plots to figure out which gene profiles mean the most when a particular patient presents. And you can see here the curves with the dotted line being the most recent time period studied from 2005 to 2008 with the highest number of long-term survivors. And we took this, and on the sort of left side of the screen here, you can see in orange, these are patients who were defined as very short-term, meaning less than 9 months, and then compared to greater than 2 years. And we took a whole host of gene profiles and figured out where were the ones with these little green dots that had specific mutations in long-term survivorship versus short-term survivorship, and then plotted those. And what we found is a really interesting pattern that you see this green here signifying upregulation in short-term survivors, and in a corresponding way, either black or red, meaning that the opposite is true. Either the gene is either turned off or upregulated. And we then started building animal models using these putative gene knockouts to figure out, could we in fact replicate the survival patterns? And it turns out that with about a 90% sensitivity and specificity, we had an ability to predict how the patient actually ultimately did based on the tissue that was implanted in the actual animal model. So now we're trying to reverse engineer that so that when a patient comes to our hospital and they get surgery for a GBM, we actually take the tissue from the OR, implant it into an animal, and that animal becomes almost like an avatar, a real-time mimic of the patient, and then we can use that animal model for drug throughput and targeting of putative treatments and figure out really which is the winner, which does the best, and we can do it hopefully within a 1 to 2 month window so that it actually becomes relevant information for treating the patient. One particular microRNA that seems particularly promising is microRNA 424. There's 1 million of these, and you know, you can go through a long list, and everyone has their pet putative microRNAs, I'm finding out, but at our place, this is the one that had the starkest contrast between short and long-term survivors, and it turns out that when this is downregulated, you can actually turn what otherwise would be a short-term survivor into a long-term survivor in some of our early animal studies. So lots of, I think, exciting things on the horizon. We also are looking at exosomes as biomarkers that we can follow, and these, of course, are intracellular vesicles that act as communication pathways between these cells at electron micrograph. You can actually see these little vesicles here on the cell surface, and they have different ways of communicating in terms, they can directly bind with a target cell, they can transfer nucleic acid, and it turns out that they are very involved in angiogenesis and cell invasion and a host immune response, which we think interplays with some of the microRNA work that we've been doing. So we have pieces of the puzzle that are scattered and trying to sort of put it all together that makes sense. And if one of you may recognize BRAF as sort of the wonder drug target in melanoma, which has revolutionized that field. So coming here yesterday, I had a layover in Atlanta, and I saw the cover of Time magazine. Did anyone see that? The cover of Time magazine this week must be a slow news week, but nonetheless, it shows 2 patients diagnosed with GBM. One was put on a clinical trial, one was not, and the whole article was about the rise and importance of precision medicine and targeting therapies for some of these dreaded cancer types. And one of the newest drugs involves the same BRAF pathway that was used in melanoma, but wrapped in a way that it can get into the blood-brain barrier and so forth. So it's gotten into the popular press, and so one day, who knows, you might just be able to do a blood test and figure out what someone's genetic markers are and go from there. And that might turn us into this, and maybe some of our colleagues would like to see this happen. I think there's always going to be a role for neurosurgery. But when we think about innovation and how to push the field ever forward, like Cushing must have thought about at the beginning, the possibilities are limitless, especially in the world of nanoparticles and exosomes and being able to use advanced molecular imaging to develop these personalized targets. And even I think Cushing himself noted that he'd like to see a day when basically we're out of business, not quite, but essentially noting that the operative part sometimes is the least important part of what we do, especially in malignant gliomas, because you have to understand the pathology that goes behind it. So again, here's the challenge, and the challenge, of course, will always involve some aspect of surgery to make a difference for our patients in a safe way, because you have to decrease the mass effect, you have to get the tissue, you have to understand what the molecular markers are, and it is true that the more mass that you remove, the better patients do. But here's the challenge, and this is a pretty important concept that just is at once very telling and depressing, but it lays out what needs to be done. So in the preoperative state, you have a solid mass, but within about 2 centimeters, you still have about 6% of tumor cells that are not in the enhancing portion on an MRI scan. So this might be your flare abnormality. But another 2 centimeters out, which is seemingly normal brain on an MRI, you still have a couple percentage of the overall tumor burden that's already there. So now you think you're this great talented surgeon and you have all the bells and whistles, and you take this out. In the postoperative state, there are actually cells that potentially could be in the contralateral brain. And so we know this now from pathology studies, and the question is, that they spread through classic white matter pathways, through CSF pathways, through direct contiguous spread. And the question is, how do you combat this? You still need an expert surgical removal to give the patient a fighting chance, but you need something else, whether or not it's molecular targeting or combining radiation and chemotherapy. And that's what the Stoop protocol begins to address. And this is pretty standard now across the country. I think we're all familiar with the concept of a maximal safe surgical resection, 6 weeks of concurrent radiation and temozolomide, followed by 6 months of temozolomide. That really defines the protocol, and that's made a difference. This is what typically can happen in that early stage in a successful patient over about a 6-month period of time. The goal, of course, is preventing recurrence. But when you start to look into markers and figure out which patients have a methylated MGMT promoter, which is critical to determine their receptiveness and response to temozolomide, they do significantly better. And so a lot of research around the country is going into now figuring out if you are an unmethylated MGMT promoter patient, what can be done to methylate it so that you have a better chance of survival. And so you'll see, I think, a lot of work and papers coming out regarding that, including at our national meetings in the coming few months. So a decade ago, the teaching, the mantra was that in order for surgery to be relevant, in other words, you shouldn't even consider surgery if you would only get a certain percentage out. And the LaCroix paper from 2001, the seminal paper, basically suggested that in order to achieve statistically significant relevance in survival, you needed to take 98% of the tumor out. And that's a pretty high bar given the pictures that we just discussed. But nonetheless, when you do, there's a significant increase in survival. Turns out that over the last several years, that's been refined by Mitch Berger and several others around the country, where truly with a larger series, it looks like that threshold is now 78%, and each sort of percentage decile that you go up, 80%, 90%, 100%, you actually see a pretty significant progression in survival. So we know that extent of resection matters. The question is how best to get there, and how can we achieve this while also still targeting those distant cells. So at our place, we lobbied hard over a period of years for an intraoperative MRI, and we finally got it a couple years ago, and it's actually changed the way we conceive of doing certain types of brain tumor surgery. Low-grade gliomas, for instance, are much more easily resected when you can see in real time what's left. But what was interesting to me, and this was a learning point, is that even for glioblastomas, when I thought, okay, well, this is a necrotic mass, it's enhancing, it's obviously different, even through a microscope or through your loops, you can tell, when you're around the tumor. That wasn't always the case. And when you get advanced imaging, when you combine this with functional imaging, you can actually do much safer surgery. It allows us, for instance, to get nearly all of low-grade brain tumors out, at least all of the radiographically abnormal areas. That extent of survival sometimes correlates to a 20-year difference in survival. If you can get, let's say, 75% out versus 99% out. And even for malignant tumors, our data suggests that those patients who became long-term survivors, meaning that they lived greater than 3 or 4 years, part of it was because they had an initial resection that was significantly more, or at least a larger percentage of them had a gross total resection. So with new brain lab technology and other vendors that are now upgrading their capabilities, you can actually link a patient's functional MRI and DTI with intraoperative navigation in real time, so that you can figure out not only the cortical surface where to avoid, but actually the descending white matter tracks in terms of how to make surgery safer for patients, so you don't undercut those fibers and still have them wake up with a significant motor deficit or speech deficit. But this is what was so telling for me. This is one of the first cases that I did, pretty obvious standard tumor. And this is the point where, honest to God, okay, I thought I was done. I got everything, under the microscope, looked completely clean. This was normal, sort of tan-colored, pinkish pulsating brain that was, not at all a consistency that you would think would be tumor. But this was our intraoperative image. And it turns out that this whole rind here was still abnormal. And so we went right back in and got it. And this patient 3 years later is alive and well. I'm not saying it is entirely because of this, but you have to wonder, if you have the ability to look more closely on a very different level in real time, it can certainly help. One of the other things that we've started simultaneous to the intraoperative MRI is 5-ALA, and this is many of you I'm sure are familiar. It's a non-fluorescent enzyme that's taken up specifically by tumor cells, and it does this for several reasons. One, there's a disrupted blood-brain barrier, there's increased neovascularization, there's membrane transporters that are very specific to malignant glioma tissue that are not present in normal brain. So it has a very favorable contrast ratio between normal brain and tumor. And so what happens is these abnormal cells take up the non-fluorescent portion of 5-ALA. The patient, right before surgery, is given a prodrug, which is essentially a milky liquid that they take orally. That then causes protoporphyrin to accumulate, and when that happens after a period, it really just takes about 30 to 45 minutes, you can shine a light on it with a special, it's a blue light emitted from a special filter on our operative microscope. And in fact, all of that 5-ALA that has been taken up by the tumor turns this brilliant red-violet color. And it's, you know, I tease the medical students that it's like, you know, when you're in med school and you look at the Netter drawings and, oh, there it is, it's obviously colored red or pink or purple. Well, in real life, you know, we're beginning to get at this, and it actually is very, it's very telling, because, again, many times we'll be at a point where we think that, you know, we're done, and we bring in the microscope and shine that blue light, and lo and behold, there's lots of tumor that's still lighting up, and that has also helped us tremendously. One of the other advances that we've started really over the last year is using laser thermal therapy ablation for specific kinds of tumors, and I think this is, you're going to hear about this more and more over the coming years. But essentially, it's a probe, and you place a little burr hole, and it's as if you're doing a stereotactic biopsy, but you're inserting a probe that has the consistency, essentially, of a uncooked piece of spaghetti. It's that thin and fragile, but it's put through a sheath directly to a target. When you have an intraoperative MRI, you can exactly localize where you are, but the goal is to get in this zone here, where you're not vaporizing tissue, but you're actually denaturing proteins and so forth, and causing cell death, specifically in tumor tissue, while leaving normal brain tissue alone. And this is what this probe actually looks like. It's cooled with saline, and it connects to whatever MRI system you use. It doesn't have to be intraoperative MRI. It can be a regular diagnostic scanner. But essentially, in real time, this is what the screen looks like. And so you can see the lesion here when there's a catheter in it with this laser probe essentially lighting up. And as the heat gets to a point where it causes cell death, and you can program this to any color you want, but in our case, yellow means that it's sort of done. It's cooked, it's fried. And one of the selling points of this treatment is that you can actually see it in multiple planes. You can have a bird's eye view, and it really is meant for lesions that you can't otherwise get to surgically. So we often use it, for instance, for deep-seated Mets that have failed radiosurgery and that have come back. We're actually beginning to use it for thalamic GBMs, another difficult open surgical target, but one which is sort of begging for better treatment. And when you compare laser ablation to either high-frequency ultrasound or even cryotherapy, the transition zone between the kill zone, if you will, and normal brain is anywhere from 5 to 10 millimeters in these other modalities. But in laser therapy, there's such a steep drop-off where it's really about a millimeter. And so we've done lesions that are basically in or abutting the brainstem, and the patients do fine. They all go home the next day. And to my amazement, the other thing that happens is that the heat is taken up in the abnormal tissue. So even if you have this very odd-shaped oblong tumor, it doesn't have to be a perfect sphere. Somehow the laser conduction fills that odd contour, and the end result looks as if you planned it exactly as the shape of the tumor. And so you have to be willing to wait out a period of swelling. But one of the first cases we did about a year ago, again, this thalamic lesion here, and literally the next day you see sort of a double ring phenomenon where it's kind of hard to see, but inside is the region of the tumor, and then this outer ring is this ablation zone. And then it actually looks worse before it gets better, and you can imagine we were very concerned as to what was happening during these 2 weeks. But the amazing thing is, by a few months later, it actually starts to recede and fade away. And this patient is still alive today, and the scan looks exactly like that. So it never really disappears. But you know, to get a GBM in this location and of this size, you know, a year ago, you wouldn't expect necessarily that result. So I'm pleasantly surprised with the outcome so far. We'll see what the future holds. But you know, all of these innovations, and I just, for anyone in the room, I don't know if anyone can take a stab at this, but do you have any idea what these innovations have in common? People discovering heparin, insulin, using ether anesthesia for the first time, double lumen catheters. Believe it or not, every single one of these was, quote unquote, discovered by either a medical student or a resident or somebody in their training. And so the point is, it's never too early, or it's never really inappropriate to ask some basic questions. And one of the ways our viral therapy enterprise has happened over the years is when a couple residents did exactly that. And one of the things that we're piloting at our place, along with UCLA and Cleveland Clinic, is this concept, and the brand name of this is Tokogen, but it's essentially a Trojan horse philosophy where you're trying to get a virus secretly into a cell without the tumor cell knowing it's there, and then at a specified time you sort of pull a trigger, the concept again of this prodrug that turns on a killing mechanism to selectively kill the tumor cells. And the reason that I think a lot of viral vector therapies have failed in the past is because most prior approaches used non-replicating viruses, and they just simply couldn't get the load that was needed to sort of eradicate the tumor burden. This is a replicating viral therapy. The second reason that others have failed in the past is that they were oncolytic viruses. Oncolytic viruses tend to have a very robust inflammatory response, which was like waving a red flag to the host immune system. So quickly the body's immune response would come and sort of shut that down, and it wouldn't have a chance to do its job. And so this is a new way of reimagining this therapy, where it's a retroviral replicating vector that essentially reproduces by budding from the host cell, but it leaves the host cell intact. And so it's, in essence, these cancer cells become factories for these replicating particles, which then can spread throughout the tumor. And the interesting thing is, as they're allowed to hide and spread in these cells, they do not create this inflammatory response, and therefore they evade detection by the body's own immune system. And so what we do is essentially, at the time of surgery, and there's two arms of the trial. One, patients get intravenous viral vector therapy, and the other, it's directed directly into the surrounding tumor cavity. But essentially, over a period of several days and weeks, that virus begins to spread through the tumor after the surgery. The patient, at about a month, is given a drug, cytosine deaminase, that converts a dormant portion of this virus, 5FC, to the killer portion, if you will, of that same entity, to 5FU, and then that causes apoptosis specifically and only in the cell in which it's embedded. And because they can only selectively be taken up by tumor cells, there's, in theory, a whole period of time where there's significant cell death that's happening. In our preclinical models, oftentimes this is repeated 4 different times, and the animals lived something like 5 times longer than their non-treated counterparts. In our current clinical trials, we have about a 25% improvement in survival in patients on this therapy. So again, it's very promising, but we don't know all of the answers in terms of why some patients respond so well and why others don't. But it's again another piece of the puzzle. One very interesting thing, talking about innovation and how the past ties into the future, is this concept of Raman spectroscopy, and it's something that we've been investigating now for a couple years at our place. And it actually, taking a step back for a second, has a very long history, and it's related to this concept. Many of you may recognize this author who was actually at one of our national meetings a couple years ago, Stephen Johnson, where good ideas come from, and Neil knows very well. And it's the concept of, when you're looking for ideas, you should find ideas that are adjacent to existing concepts. The concept of, quote, the adjacent possible. 2 steps away is too far and will never happen. But if you can get 1 step away, you're nearly there. And it's this concept of interconnected doors in a house. You can't reach the final room until you travel sequentially. That's why, for instance, you know, televisions weren't invented in the Renaissance. There was a million different things that needed to happen in between to make that happen. And so why am I talking about this? Well, I'll digress for just a few minutes, but I think it's a pretty cool story. So in the late 50s, the world was crazy and awash in the concept of the Cold War. And the Soviets had just launched the first satellite, Sputnik, into space. And at MIT, there were two 25-year-old graduate students. They knew that this launch was happening and that Sputnik was in its orbit. And they asked their professors at MIT if they could actually use some new sound equipment to listen to this. And what's interesting, and as Stephen Johnson tells the story, you know, they discovered something that was actually quite unique, and that is, at that time, what today we all know, of course, is the Doppler effect. But if you have a moving source that's oscillating or changing position, the wavelength changes, and so low frequency, longer wavelengths, smaller wavelengths, higher frequency. It's when you hear a siren coming or going. It all makes perfect sense to us today, but it was a novel concept at the time. But then the innovative thing was they asked, could they do it in reverse? And so this same technology, believe it or not, was actually used to discover the placement of nuclear submarines, because that same principle of emitting sound and wavelength, you could actually find where it was coming from. So that piece of military technology went through several iterations over time. The development of the transistor and microchip technology, the concept of having a cell phone, the rise of the internet, and then most recently, longitude and latitude specific data uploading, the whole concept of social media. And so you can really make the connection between two graduate students at MIT asking a simple question to today. That is the very reason why we have GPS in our cars and in our phones and everything else. And that is related directly to the concept of Raman spectroscopy. And I'll tell you why. So basically, in the early 1900s, Professor Raman was at the University of Calcutta in India. He discovered this so-called Raman effect, which I'll tell you about, and he actually was awarded the Nobel Prize 2 years later, the fastest turnaround time ever. And this technology was actually developed by the Department of Defense 10 years ago to help detect wartime improvised explosive devices in the field. And it did this with inelastic light scattering, basically filtering light waves actually produce a unique spectral fingerprint. And so if you do that on a microscopic level, you can actually determine particulate matter in the air or potentially tumor tissue, what it is that you're dealing with just from a different way of scattering light. But there were certain challenges. At the time, a decade ago, it took up the size of a machine that basically the size of a room, and it took basically several minutes to hours to get a result. Well, that same GPS technology, that same advancement that turned the Doppler effect into GPS was at play here over relatively the same time period, and there was an opportunity we had at Henry Ford to look at tumor tissue in Raman to see if it could actually be relevant. And the whole point was figuring out what is this Raman effect. And so basically you shine a laser light at a particular sample, you measure the spectrum of the light that's reflected, and then each output of that exercise has a unique fingerprint. So we asked, you know, could you take fresh tissue from the OR or even intraoperatively and use some sort of probe or way of shining light to actually figure out what it is that you're dealing with, and at the same time, could you actually ablate that tissue or at least know further, you know, how to resect it? And so at our Hermelin Brain Tumor Center tumor bank, we took about 580 blinded tissue samples of an array of brain tumors, so meningiomas, normal brain from epilepsy patients, anaplastic astrocytomas, glioblastomas, and sent it to our partners at the engineering department at the University of Michigan and later at Wayne State, and essentially created a data set for them to test against to see if in fact Raman was relevant. And it turns out, amazingly to our surprise, that with a 99% sensitivity and 97% specificity, they could predict, after unblinding this, which type of tumor cell that it was. And that same advancement in GPS technology that was at play with what we just discussed decreased the time for a correct diagnosis from about 47 minutes to a fraction of a second. So now this became very interesting to us, because could this in fact be used in real time to detect tissue? And the final advancement, if you will, is that that room-sized piece of equipment that was used a decade ago in the Iraq War to sample IEDs on the roadside basically could now fit into the tip of a probe. It looks exactly kind of like the navigation probe that we're all familiar with. And so with laser light at the tip of this pen, directed in an intraoperative setting, within a fraction of a second, we could actually tell whether or not it was radiation necrosis potentially versus glioblastoma versus anaplastic, and then could those cells be destroyed selectively when we used it. And so we went through a whole process with our engineering counterparts that is way above my head, but essentially converted tissue to these spectral maps. And it turns out that normal tissue was very significantly blue, tumor tissue was this turquoise color, and necrosis was reddish orange with some infiltrate. And then we matched it up with varying pathology samples, and there was a correlation between all types of normal tissue and these spectral maps, actual tumor tissue, and again, these different colors, and then again with necrosis. And then we put it all together and patented this probe about a year and a half ago, and now have begun to actually use it in real patients. So again, using our navigation and then using this probe to actually sample tissue. We've taken about 25 patients through this process and basically assigned tumor, necrosis, infiltrating, or normal, and then within tumor, which specific grade. And you know, in this particular case, you can actually take the intraoperative MRI image, the navigation location, the pathology from where that was, and the spectral map from the Raman probe, and it turns out that they are all matching up pretty well, each with their own unique peaks, but nonetheless internally consistent, to the point where regardless if it's high magnification or low magnification, you can have gray matter versus white matter versus tumor tissue versus necrosis, and you get a unique map that is internally consistent across all levels. And so far with those 25 patients, we've had about a 94% correlation between our Raman real-time results, which is done, it takes a little bit longer, it's about 4 seconds, versus pathology frozen section, which I don't know about here, but in our place it's about 45 minutes on a good day. And so with this new technology, you can begin to maybe imagine pushing the envelope across multiple classes of molecules and multiple combinations of features that you might find in a particular pathologic specimen to really inform what patient treatment should be. And so this old way of waiting 20 minutes, or as I said in our case, sometimes up to 45 minutes, might now be a situation where you're in the operating room, you're using this probe, within a few seconds you know what it is that you're dealing with, and then you can actually develop a treatment paradigm that is relevant for that particular patient. And so I think that when we talk about the future, there's lots of exciting opportunities for pushing the envelope further. My goal in our lifetime would be hopefully to see this curve jump significantly, and I think that there's not one right answer, there's not one magic bullet, it's many things. Glioblastoma multiforme, the word multi means that there's a very heterogeneous group of tricks essentially for evading capture, and we have to be 10 steps ahead. But I think that I've never been more excited in my career or listening to my mentors who've come before me about the advancements in the past than in the time period we're living in now. So I think that there's certainly much more to come, and we'll see what happens. But again, this is the goal that I think we all have, these devastating tumors in a devastating location, and how can you turn this picture into that? And this was a patient who was on one of our BRAF clinical trials from a couple months ago. We'll see how long this lasts, but it's certainly one of the most stunning displays of regression that I've seen, and I think that hopefully we'll have more patients like that in the future. And just as a reminder how the paradigm is changing, you know, it used to be that if you have a recurrence on your imaging and maybe you present that MRI at tumor board, you say, okay, well maybe we'll put this patient on a second generation drug or a third generation drug, or we'll try re-resection. But essentially the only way currently that we have to assess whether or not a particular intervention has worked is to do follow-up imaging, and that can take multiple weeks or months, and by that time, you know, it may already be too late, especially if you find out that in fact it hasn't worked, because most of the time there's really no actual confirmation if the drug you're giving is reaching the target. There's not a clear understanding of what, you know, the molecular mechanism of action is, and it takes too long to be relevant for patients who may not live this long. And so I think that some of the things that we touched on today, exosomes and even the Raman analysis, but certainly intraoperative adjuncts like 5-ALA and the viral vector therapy can actually move us toward this concept of a molecular tumor board, where a better understanding of the molecular genomics of what makes these tumors tick, and why in some patients who have an identical scan and an identical pathologic diagnosis, one lives 6 months, the other one lives 6 years, it's because of this interplay with up and down regulation of the actual tumor genetics, and that's something that I think will allow us to build a more personalized therapy, a truly personalized medicine approach for these patients. So I thank you for your attention. I invite you all to Detroit. Warmer weather is upon us there, and I hope to see all of you just down the road in a few months for the CNS meeting in New Orleans. So thank you very much for inviting me.
Thank you, Steve. Any questions? It was an excellent, I was really up to date on where we stand with technology and stuff like that. Yeah.
Is the Raman technology sort of tested, or is it
It's still being tested. The next step is to sort of do it more widely in patients. We've done it in an in vitro setting, and we just have literally 25 patients so far. So I think we'll see what happens in the next go around. So.
Ben?
What's your take on other treatments for recurrent glioma, electronic tumor treating fields, or maybe radiation, radiosurgery?
You know, I think that every patient's different, and I think that everything has to be evaluated individually. I don't think there's one right answer. I'm a big proponent of trying it, and I think that there are certain, for instance, new vaccine trials that might be relevant. You're talking about the electrical field cap. We have a few patients who it's very striking to see them walk into your clinic with this contraption on, but you can't argue with the fact that there's something is happening, because the data suggests that there's, you know, the curve is shifted slightly. The question is, you know, you may be buying a few weeks, and that's great, but we need to be buying a few decades, and obviously we're not there. So it's all to be determined.
Are you using your Raman spectroscopy at the end of your resection at all, like to check your borders?
We are, exactly. And so we tend to do it, I tend to do it when I'm in the intraoperative MRI, so the point at which I think I'm done, you know, we do it at the beginning, but then at the point where I think, okay, we're going to get a scan to see, in fact, how much is left, we do it then, and we're correlating the images as well. So.
Well, thank you very much indeed. On behalf of the department, we have a little plaque for you.
Oh, it's beautiful. Thank you. Great. Thank you.